Thank you, everyone, for your understanding. We're actually broadcasting. Dr. Andermann is in a different country, so apologize for some of the technical things. So normally you wouldn't see the background stuff, but thank you for joining. It is a great pleasure to welcome everyone to the citywide grand rounds and the start of the new academic year. And hopefully everyone had a good summer. I'm going to start off by reading a land acknowledgement. I would like to acknowledge the land in which we work, study, and live. Before I read it, I want you to take a moment to situate yourself and think about the land under and around you. We recognize many indigenous nations have a long-standing relationships with the territories upon which the sites of Department of Psychiatry are located, and precede the establishment of the University of Toronto. We acknowledge our presence on these traditional treaty of many indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis people, and we're grateful to have an opportunity to live, work, and gather in these territories. We acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and Williams Treaty, signed with multiple Mississauga and Chippewa bands. Since this event is a virtual gathering, a singular land acknowledgement does not fully capture the richness of our distribution across many locations. There are few places on Earth that someone before us has not called home. So thank you for that. I'm just going to see if I can quickly share my slides here. Sorry about this. As I said, Dr. Andermann is going to be doing a wonderful presentation today, and it is in recognition of her winning the Harinder Gained Bending the ARC award in 2023, and I wanted to acknowledge that as well. And also acknowledge Dr. Gaines' mother, who the award is named after. Evaluation link will be sent at the end of the presentation. Your feedback is always appreciated. The next citywide grand rounds is going to be by Dr. Mark Senior, and I think it'll be an exciting one, so please mark that on your calendar. Now, without further ado, I'm going to introduce our speaker for today. It's a great pleasure to introduce Dr. Andermann, a friend and colleague and an exceptional scholar, and I'm so grateful that she's agreed to speak today. Dr. Andermann is Associate Professor of the Department of Psychiatry, University of Toronto. She's the co-chair of the Advisory Council, EDIIA, in Clinical Care, and the Director for the Toronto Addis Ababa Psychiatry Program, TAAPP. In addition to her work in Mount Sinai's Ethnocultural ACT team, Dr. Andermann is a consultant psychiatrist at the Center of Victims of Torture and with the Northern Psychiatric Outreach Program, providing outreach to remote communities on Baffin Island. Dr. Andermann co-edited a book entitled Refuge and Resilience, promoting resilience and mental health among refugees and forced migrants. She is a former board member of the Society for the Study of Psychiatry and Culture, and currently a board member with the World Psychiatric Association of Cultural Psychiatry. She's been awarded the Harinder Gained Bending the Arc Award, the Don Wolaski Award for Social Responsibility in the Department of Psychiatry, the Amina Amalko Award for the Center of Victims of Torture, the Social Responsibility Award, Postgraduate Medical Education, for work on underserviced and marginalized people in 2015. She has an undergraduate degree in anthropology from McGill University, where she completed her medical studies, and a graduate degree in social anthropology from Cambridge University. So with great pleasure, please welcome Dr. Lisa Add.
Thank you so much, Raj, and thank you also to the Sonu Gand and the Gand family for creating this award, and I'm very proud to be the inaugural recipient. I'm just going to share my slides so we can get started. And let me see what is happening. Sorry about that. Okay. Since I can't really see any of you, you can maybe give me a thumbs up. It looks like it's okay right now.
Yes.
Yes, perfect. Thank you. All right. So I'm speaking to you today from Ethiopia, where I'm on a teaching trip this week, together with 2 U of T faculty and one resident, Talbir Mandur, who was here helping me with the technology at the last nanosecond before we started. So I'm very grateful to him. I'm also here with Andrea Waddell and Gail Robinson, and they have I'll tell you a little bit more about those adventures in a minute, but just wanted to start speaking about the learning objectives for today, which are to discuss the contributions from 20 years of the Toronto Addis Ababa Psychiatry Project, or TAAPP, as an example of a successful teaching partnership. By the end of today, we'll also be looking at strategies for providing effective, culturally competent newcomer and refugee mental health care, which has been another large part of my practice and career, looking at the impact of post-migration stressors on mental health in these populations, and also looking at how some tools and approaches from cultural psychiatry can be useful in local and global mental health. And I decided to start with 2 quotes that have inspired me. One is by Paul Farmer from Addis, which I highly recommend. These short kind of written pieces are inspiring, they're hopeful, sometimes very funny, sometimes very honest. And this quote today about partnerships is really been the, I would say, reason for success of the TAAPP program, but also many of the other initiatives that I've been involved with over the years in cultural psychiatry and in global mental health. The next to share is from Arthur Kleinman, psychiatrist and anthropologist at Harvard, who is speaking about the dangers and risks of medicalizations, where we are sometimes tempted as psychiatrists to transform suffering into clinical diagnoses, and looking at, well, not looking enough at some of the moral consequences of political violence when it can be labeled as PTSD, how suffering is redefined as mental illness and often treated with medication. And this does not give us a full picture of the person. So I had the good fortune in my PGY4 residency year to spend 6 months working and taking courses both with Arthur Kleinman and with Paul Farmer in the Department of Social Medicine at Harvard. And those experiences have stayed with me and have informed a lot of the work that I have done since that time. And I made this little graphic to show how cultural psychiatry has really been the kind of guiding force and the thing that helps me to make sense of all these different areas. At Mount Sinai, to global health here in Ethiopia, to outreach on Baffin Island, to using some medical anthropology and cultural psychiatry practices and principles in my clinical work. And also linking, if you see the image, the black and white image on the far left, that's a photo of my grandmother, Dr. Mina Deutsch, who was a psychiatrist and also a Holocaust survivor who came to Canada as a refugee in 1948 and had to redo all of her medical training here in Canada as an IMG, which was, as you can imagine, was very difficult, especially in those days. And some of those experiences that she spoke about and part of my family history have also been inspiring for me. And just another graphic showing how, you know, this kind of central knowledge pool of cultural psychiatry has really been able to inform all of these different areas that I've been working in, as well as advocacy and community engagement, which, you know, is really what the gained award in Bending the Arc towards social justice encapsulates so well. I'll start by telling a few a few stories about the first 20 years of TAAPP, which is the Toronto Addis Ababa Psychiatry Program. This program was started in 2003 with two main objectives: to assist Addis Ababa University to build capacity and sustainability for the first psychiatry residency training program in Ethiopia. And it's also been an opportunity for the University of Toronto Department of Psychiatry to understand and develop the skills and knowledge necessary for educational outreach partnerships. So for those of you who don't know where Ethiopia is, it's located in the Horn of Africa. It's surrounded by Kenya on the south, Eritrea on the north, Sudan to the west. There's a tip of Djibouti right in the tip of the Horn. And Addis Ababa, where our program is based, is right in the center of the country in the Ethiopian highlands. And this is just an image from the celebration booklet from the 20th anniversary with some of the key people who've been involved over many years. Right now, TAAPP is part of the larger TAC, Toronto Addis Ababa academic collaboration, which is being led by Dr. Dawit on the far left of that photo and Marcy Rose on the far right of the photo. So going back 21 years, the first Ethiopian psychiatry residents were a class of 7. And these were the first people to be trained in psychiatry without having to leave the country and make their way to other parts of Africa, to Europe or North America to do psychiatric training. So it was a very exciting time. Those of you who attended Claire Payne's professorial rounds last year got to hear a little bit more about some of her personal experiences and really being one of the Canadian founders of the program. I was very fortunate to be part of the first official teaching trip in November 2003 with Dr. Brian Hodges and Kevin Chopra, who was our resident at that time. And this trip really allowed us to create the foundation, the template of the subsequent teaching trips. And we're now on our 45th month of teaching. So there were a lot of firsts in this new endeavor. We kind of changed up the classroom, got people away from sitting in rows with the professor speaking at the front. Here's Brian Hodges playing himself the first simulated patient. Trips continued over subsequent years. In early days, there were 3 trips a year. Now it's scaled back to 2 trips a year. This is Sam Law and Sam Packer, and resident in the center, Andrea Bernsen, who is now faculty, of course, and teaching about community psychiatry, alcohol and drugs, mood and psychotic disorders. There's John Tashima and Carbon Weeb a couple of years later. And in 2008, after the first class of psychiatry residents had graduated, and it's a 3-year program, so they graduated in 2006, TAAPP grew into TAC, so this Toronto Addis Ababa academic collaboration, which now involves many programs, close to 30 in the Faculty of Medicine, and 5 other faculties at U of T, including law, engineering, library sciences, social work, and pharmacy. So all of these programs are going over there to teach, bringing trainees, and really doing a lot of amazing work, as you can see if you go to the site. TAAPP has also been part of my personal life and family life. It's at the Ethiopian New Year's Festival, Christy Pitts, and here local Ethiopian community in Toronto, and try to really work hard to promote TAAPP and make connections and network with as many local Ethiopian community organizations and individuals as possible. And TAAPP has been recognized in a couple of exciting ways. It was highlighted as an example of a successful collaboration in the 2022 World Mental Health Report, which was a nice kudos. And I want to spend a moment talking to you about the principles of TAC, the kind of guiding ideas and values of the program. So these have been described and published, and there's been a lot of academic work that has come out from the TAAPP collaboration. But one of the first principles is that the curriculum is overseen and owned by Ethiopians. So we don't, kind of bring curriculum or decide what to teach. Our Ethiopian colleagues at Addis Ababa University make requests for topics, for specialty areas, for different kinds of things that they want to use to enhance the curriculum that they already have and that they're delivering. Another very important principle is that academic credit and authorship is shared for all works. So if there are 2 Canadian authors, there are going to be 2 Ethiopian authors on any paper. And, part of this is to really try to open doors for publication and career development and mentorship for some of our junior Ethiopian colleagues. A third principle is that University of Toronto faculty are invited guests. So this is an important one. We are there to offer, but not to suggest or advise unless we're really invited to do so. And the fourth principle is to really bring some self-reflection and reflexivity about purposes and effects of what our curriculums are doing and what these exchanges are bringing and creating. One example might be, emphasis on the DSM, for example, in a country that also has a lot to contribute in terms of local beliefs about health and illness and traditional healing. I'll talk a little bit about that in a moment. So cross-cultural aspects of teaching and challenges for TAAPP have to do with, those early days of the formal versus informal style. I think we've moved kind of past that. People are very happy to work in small groups and present cases. And it took a little while, though, at the beginning. And the curriculum development has been organic over the years. We've introduced things like a formative evaluation, but we're not really the ones who are passing or failing students or doing final evaluations. This is all kind of learning along the way. Future plans for TAAPP. We've been back to in-person teaching since September 2023, 1 year ago. So we've had already 2 trips in 2024. This is the second. We're about to start a retrospective evaluation of TAAPP, including surveys with faculty, current residents, TAAPP graduates, and we have REB approval for that with assistance from people at the Wilson Center. And there's also an exciting new child psychiatry fellowship at AAU, and we had 2 child psychiatry fellows visiting Toronto for an observership from April to June and spending time at Sick Kids, CCMH, and also CAMH, and some other collaborations, including linking and learning together from psychiatrists and traditional healing. And these are just some photos of visiting holy water sites for Orthodox Christians. This is really the first place that people go for any illness, mental illness or physical illness. And there's a very large Muslim population in Ethiopia as well, who also have their own traditional healers. These are just some publications that have a bit more information. I'm working on that with Sam Law and Ribka Birhanu, who's a junior faculty here, who also spent a year in Toronto, and Professor Jonas, who is really the one who has worked on this together with Dr. Dowett, and it's ongoing. So what TAAPP is delivering and has delivered are 45 one-month U of T teaching trips with 2 faculty and 1 resident, delivering core content based on the Ethiopian curriculum. We have clinical supervision and feedback, including things like mock orals and interview skills. We have co-trained over 130 psychiatrists through this program, and the faculty at AAU have increased from 3 to 30, and they are now creating their own exams, with the exception of having an external oral examiner outside from U of T, Dr. Nick Cates, who's been doing consistently the oral exam since 2006, which has been incredibly helpful. There are also some evaluation tools for formative evaluation and oral exams. And Claire Payne and colleagues at AAU had done some core competency work adapting CanMeds into an EthioMeds framework. So the main outcomes of TAAPP, this is just a graphic from the 20th anniversary. I think I've covered most of this other than saying that with TAAPP graduates, there have now also been 6 new departments of psychiatry that have been established around the country, so outside of Addis Ababa. So the impact of TAAPP is really spreading broadly. And through TAAPP as well, there has been some advocacy work, getting psychiatry kind of included more in primary care through a national mental health strategy of Ethiopia. That was before my time, and summarizing some of the work that's happened in these 20 years. So plans for mental health care to be further integrated into primary health care are ongoing. A quote from Professor Atele, who was one of the original founders of TAAPP, is that it has enabled the Department of Psychiatry at AAU to be the fastest growing department on the continent, with significant bearing on the enhancement of mental health services in the country, which is a great compliment, and that TAAPP has produced a workable, effective model for accelerating the creation of medical specialists in Ethiopia, and this model collaboration for AAU. We have also brought back to Toronto some learning and momentum. This has helped also in improving and increasing the curriculum in cultural psychiatry and in global mental health. Okay, so some lessons learned: that the role of relationships is central, both personal and systemic relationships. We have thought about, bringing urban Toronto super specialized psychiatry to Addis Ababa, whether we have unwittingly, included too much emphasis on the DSM at the expense of personal and social history gathering, which is still something that we are working on during every trip. Part of the trip is really to provide increased clinical supervision, because resident workloads are very high. And, the idea of having 1 hour to see a patient and 1 hour to talk to your supervisor, really is not the reality in many parts of the world, including Ethiopia. But having faculty sitting in clinics and sitting in morning rounds and being able to just be more of a presence has been one of the things that we've worked on during the teaching. So we have about a 30-70% split, with 3 afternoons in the classroom and the other 7 afternoons either doing clinical work or mock orals, kind of oral exam interview preparation. So the other is that, there are a lot of differences. There are also a lot of similarities. So it's really important that we kind of don't start sentences with, the best way is like this, or in Toronto, we do things like that. If people are doing something, there are good reasons for it, whether it's because medications may not be available or the ECT machine is not working. It's very important to practice cultural humility, and also to exercise caution if we're bringing over Toronto or Western-based trainings, to really make sure that they are appropriate and that they are going to make sense in that context. So I'm just going to end this part of the TAAPP presentation with a lot of thank yous, so I didn't want to leave them for the end. So everyone involved with TAAPP, AAU faculty and residents, and all our U of T faculty and residents who have participated, the founders of TAAPP, Professors Atele, Mesfin, and the late Dr. Abdul Rashid, also Claire Payne and Brian Hodges, who were there from the very beginning, with Paula Goring, and also Morley Beiser, the departments of psychiatry, and the presidents of both universities who have made formal partnership agreements, the chairs of both departments, and through TAC, Marcy Rose and Dr. Dowett. And there have been so many other people who have allowed this program to happen, from our travel agents to our drivers to the Guion Hotel, our families and workplaces and colleagues who have covered for us when we've been away for a month and who have, allowed us to take part in this. We are very grateful. So I'm going to pause for a moment and just switch gears to be able to talk about some of my work in refugee mental health for the second part of the presentation. So we know that, unfortunately, there is a lot of turmoil around the world, leading to people being displaced internally, also having to cross borders, becoming refugees and asylum seekers, and that there are more people than ever in the world today needing international protection. Canada has aimed to welcome some of these people. Some people are moving as permanent residents. Other people are coming as government-assisted refugees, so being pre-selected to move here from a refugee camp or from a country where they are seeking temporary protection. And then asylum seekers are those who arrive at our border by plane, by crossing at Niagara or through borders near Montreal or anywhere along our huge border, or who are being brought here with some kind of time-limited agreement, like the Ukrainians who were starting to come after the war began in 2022. So we'll focus on some of the mental health problems that we see in these populations. Most are the result of ongoing violence, forced migration, grief, and multiple loss, isolation from families, for example, and everyday hardships. The hopeful news is that the majority of refugees do very well after reaching safety. And there's a lot in the literature about how the presence of psychological distress does not necessarily indicate the presence of a mental disorder. There are certain more vulnerable refugee groups that we have to be a little bit more cautious with. However, those are people with pre-illness, people who are survivors of torture or severe trauma, women, older adults, unaccompanied children who are here on their own, people with disabilities, with a previous trauma history, and also single adults without a lot of social supports. So mental disorders in refugees, most commonly we see anxiety and depression, and then PTSD, but rates really vary widely depending on the population studied and where, if they're coming, if you're looking at a clinical population versus a community population. So these numbers are, very hard to pin down. And, even although some of the papers quote higher rates of psychosis and substance use, it's still really comparatively low compared to the general Canadian population. When we look at mental health service use, the majority of refugees do not need formal psychiatric treatment, but they also would use services less frequently than their Canadian-born counterparts for many reasons. One is disparities in access to services and health outcomes, but another is just that many refugees are coming from countries where there are not a lot of psychiatric services, and they would not really seek it out, whether it's medication or psychotherapy, because it's quite a foreign idea to bring your personal problems forward in that way. So many of them are turning to other forms of community support, religious support, and other things. So that is kind of a very frequent kind of presentation, and only coming forward when there's maybe a crisis or emergence. People out of those situations when we're help refugees, lawyers prepare documentation so that people can successful in their refugee determination. From the literature, this is a group on Canadian Collaboration in Immigrant and Refugee Healthcare, a paper written by Lawrence Kiermaier, and some principles for new arrivals. This is in particular for Syrian refugee families. But the key clinical elements of the recovery process are really empathy, reassurance, and advocacy. And we also know that social support can moderate or mediate the impact of trauma, reduce the severity of symptoms, and facilitate the recovery process. Most important in terms of post-migration are that access to adequate housing, employment, and income are really crucial to improving refugee mental health. And if we look at where psychiatrists come into this picture of a funnel of support for refugee mental health, they're really down at the bottom tip. And this is from a book chapter by Priya Raju, Deborah Stein, and Francois Dushimiamana, who really made at the top layer community-based support and schools, followed by primary care, community mental health agencies, indirect consultations, and really only a small number of refugee population are meant to come forward and see a psychiatrist. And what would the role be of that psychiatrist? Again, this is from the same chapter. There are two. One is advocacy and one is treatment. So they write that psychiatrists can and should leverage their expertise and social privilege in order to advocate for their clients. So if we're writing psychiatric reports for a refugee hearing, this can influence a life-changing determination and is one of the therapeutically most powerful interventions that we have. We also have to focus on mental health needs related to housing, accommodations in school or workplace, fair legal representation. If people are involved in court, all of that advocacy can really shape people's lives and really turn things around. When it comes to treatment for that small percentage that do need treatment for debilitating emotional reactions or severe and persistent problems with coping, as well as genuine mental illnesses, we start with basic safety, containment, and coping strategies at all levels. There are some Western psychotherapies, including things like narrative exposure therapy or NET, which have been developed with refugee populations, and some medications when indicated, especially if we're looking at things like sleep or nightmares or difficulty getting out of the house to engage in settlement activities. So their main point is that medications and individualized psychotherapies are not necessarily the gold standard solution. These interventions should not be privileged without considering both the broader social context and the preferences of refugee youth, here in this case, as agents in their own healing. So these are just some examples of post-migration stressors. We see these in the news all the time. This one says they came to Canada for their dreams. Instead, they found a mental health nightmare. This other says, I wanted to make Canada my home. Then I realized my degree was worthless here. And I included this poem from, it's a narrative, maybe not a poem exactly, but it was a project done at Women's Health and Women's Hands years ago, who were doing an immigrant and refugee mental health promotion project. And the writer, Maggie, used to be an accountant in Haiti. And now she's training as a PSW. So I was very important. I remember my country, my last job. I was very important. If one day I did not go to work, people would say, Mrs. Jean-Charles, we missed you. Mrs. Jean-Charles, we needed you yesterday. Mrs. Jean-Charles, you have to do that today. I was really appreciated. But here, I don't have anything like that. Here, I don't feel important. I can't do the same job. But in my country, I used to be important. So I've added in a couple of slides just to talk about approaches and things that might be helpful in your own clinics and settings when encountering newcomers or refugees, and just some of the things to keep in mind with working in very diverse settings like we have in Toronto, starting with the micro or clinical program level. What we do ourselves in our own office, whether we kind of take the time to try to find an interpreter or take the time to connect with a community program or settlement worker. At the meso level, there are specialized programs and clinics like the New Beginnings Clinic at CAMH or Crossroads Clinic at Women's College Hospital. And then we can also think about the macro or societal level. What are the rules and regulations that the Canadian government is making for immigration and refugee determination these days? Who has access to healthcare, who has access to different kinds of benefits and services at the larger social level that are going to determine a lot of their outcomes and a lot of their mental health, because these uncertainties that can be very prolonged, sometimes people living in limbo, sometimes for several years at a time, separated from their partner or their children, and not being able to advance in their lives because of work permits, or not being able to have funding to attend college or university as a refugee claimant, really takes a toll on people's well-being. It can take sometimes many, many years to receive status, and then to be able to start the slow work of finishing permanent residency application, and then eventually becoming a Canadian citizen. So looking at cultural safety as one of the terms that draws attention to power dynamics, institutional discrimination, and also issues of colonialism and paternalism in healthcare. We also see this a lot, especially in other countries which have been in their own histories colonizing countries, and where now people are coming from those countries back to countries in Europe or elsewhere that have then to deal with a newcomer and a previously colonized population. If we look at cultural humility, this really requires 3 commitments from practitioners, starting with self-reflection and critique, action to redress power imbalances, and also partnerships with advocates. And this is certainly something that we do a lot in our refugee work, trying to connect with settlement organizations, with refugee law office or other kind of legal aid programs that will be able to help to guide some of the things that refugees need to find out about. If we're looking at structural competency, this is really recognizing some of the structures that shape our clinical interactions, how to articulate it, and look at how things might be both blocking or also helping newcomers move forward, and having a stance or position of structural humility as well. And one of the very helpful clinical tools from the DSM in working with newcomers has been the cultural formulation interview. I think more and more people these days are becoming familiar with it, but it's still not, I would say, regularly used in a lot of work that we're doing. The cultural formulation interview is a kind of more scripted tool with 16 questions that collect ideas about explanatory models, idioms of distress, what people think is wrong with them, and what they think they need to get better, and can be easily added on to an interview with an extra 10, 15, or 20 minutes to really kind of try to get at some of this culturally sensitive information that can has been shown in research to sometimes change outcomes of consultations, change the diagnosis, the treatment plan, and patients generally like being asked about some of these aspects of their lives that are very important to them. It can also tell us when things are going well or maybe not so well with clinician-patient relationships, and can improve clinical communication and rapport. And the DSM-5 CFI grew out of the cultural formulation that existed before, which was just 5 stems that you kind of filled out the way you wanted, looking at cultural identity, ethnicity, language, And for newcomers, involvement with culture of origin and host culture, the explanatory models, both cultural explanations of the illness and help-seeking experiences and plans. So this might be where people talk about traditional healing or other ways of getting help. Cultural factors in the psychosocial environment, both stressors and supports, cultural elements of the clinician-patient relationship, and then an overall cultural assessment or formulation. And I just wanted to point out that there is a special module of the CFI that is specially created for immigrants and refugees, and I'll show it to you here. So it can really take you through all of the kind of important questions around pre-migration difficulties, migration stresses and challenges, and post-migration difficulties, and kind of take you through in a pretty natural way. So if you're kind of not sure what to ask or when to ask, this is a very good kind of guideline. And then there's a generic cultural formulation interview, which is on the right-hand side of the slide, which is taking you through, and this can be used from for any patient from anywhere. People right at home in Toronto, impasse if people aren't getting better, if things aren't working well, maybe just to step back and to ask some of these questions. So a few clinical pearls from the CFI are that it instills an approach of cultural humility. As patients are asked questions about their own values and beliefs, they're seen as experts of their own experiences. It includes a very broad definition of culture, looking at power, differentials, gender, age, ethnicity, but it also looks at other aspects of identity very broadly, identity within the family, professional identity, sexual and gender identity. And as I said, it's useful in cases of cultural complexity, or when there's a treatment challenge or something is not working out. I have a few words to share on refugee resilience, because it's important with this population, not just to think about trauma and kind of all the losses and difficulties that people have had, but also some of the amazing strengths and adaptations that we see from our patients every day. And adaptation is always about surviving and thriving in a particular place, time, and context. And resilience can mean different things to different people and to different people from around the world. So it's important to think about. But in general, it begins with early experiences and solid attachment. Community support is essential, as I have said before. Things like social supports, friendships, and ESL, English Second Language classes, as one of the really kind of important social places where people can get out of the house and feel like they're making some progress, meeting people, and learning how to adjust to a new life in Canada. And also some thoughts about post-traumatic growth, which can lead to changes in perception of the self, identifying new strengths and new possibilities, greater intimacy in relating to others, and sometimes a newfound appreciation of life or spirituality. Some themes and reflections about how the experience of trauma or torture can impact adjustment to life in the country, of getting help, psychotherapy, and family life can change the sense of one's own future and both. Oops. And we have to look at treatment barriers such as fear or mistrust. There can be loss and fear of deportation, and treatment directions, how to help people recover a sense of trust, agency, and self-reliance. The importance of social support, again, being empowered to heal. Spirituality as a means of survival, which is very helpful when people have a community here that they can just click into, and helping people with reconnection to family and community. Okay, we're just about out of time, but I have 2 slides just sharing a little bit about my work as co-chair with Meng-Xuan Lai of the Advisory Council for Equity, Diversity, Inclusion, Indigeneity, and Accessibility, EDIIA, in clinical care. We'll have a chance to hear more about these things over the coming academic year, but in the meantime, you can check out our website, which has some recordings posted now of the 2024 Advocacy Day and MindFest keynote speakers. The theme was on climate change, and there's some really good content there. Our council is finalizing summary and recommendations from our environmental scan, where we interviewed department heads at teaching hospital sites and division leads around their EDIIA initiatives, and also barriers and facilitators. You can speak to your division or hospital rep on our council for clinical care with your any ideas, thoughts, or questions, or contact us directly. We always want to hear from you, and please join our new listserv. And there was also an exciting announcement made this week, I think yesterday, about a new departmental annual event, an academic day in EDIIA and advocacy, which was previously highlighted through MindFest and Advocacy Day, with the planning committee to be chaired by Adriana Carvajal and June Lam. And a couple of upcoming dates for some cultural psychiatry conferences. And also please note our Cultural Psychiatry Day, which is free and open to everyone on Zoom on April 30th, 2025. And I'd like to say thank you to all my partnerships, in no order in particular, the Mount Sinai Ethnocultural ACT team, TAAPP and TAC, Global Mental Health with Ken Fung, my refugee mental health colleagues at New Beginnings and at CCVT, the Cultural Psychiatry Day Network, and all my other cultural psychiatry colleagues at U of T and beyond, and also the Advisory Council for EDIIA and Clinical Care, and the Department of Psychiatry for making much of this possible. So I think I'm right on time, Raj. So
thank you.
Thank you.
Thank you, Lisa, Dr. Andermann. It's an amazing presentation, and thank you. I know you're in Ethiopia, but to make the time and still do this presentation, I really appreciate it. Again, shows your commitment on in terms of the international scene of how much you are committed to improving psychiatry in so many levels. I wanted to, before we begin the Q&A, I wanted to give Dr. Sonu Gain a minute to speak, since part of this presentation is in honor of his mother, Harinda Gain, the award. So, Dr. Gain, go ahead.
Thank you very much, Raj, and thank you, Lisa, for not just this presentation, but even more for the profoundly compassionate work you've done throughout your career. You know, as the award that you mentioned describes, my mom, Harinder K. Gand, was a distinguished educator who immigrated from India to Canada with us, with her young family in the 1970s, who taught grace, dignity, and integrity through her advocacy and her example, even when facing challenges and disparities common to many immigrant experiences. And the work you've done fits so well with what she lived her life believing was important. So, you know, Lisa, thank you for having impactfully bent the arc towards biopsychostructural justice in mental health. My mother would be so appreciative of all the remarkable work you've done and honored that you were the inaugural winner of the award we've established in her name.
Thank you, Dr. Gain. That's very eloquently said, and I echo your sentiments as well. Of all the things you've done, I know all of us look up to you in so many ways. Dr. Andermann, there's a couple of questions here. Maybe I'll start with one question that you mentioned in your presentation, but I see it a lot in lots of conferences as well. But you've done a lot of work in this. Can you talk a little bit about the term cultural humility and in the context of the interview in terms of cultural psychiatry from your end, Dr. Andermann?
Yeah, thank you for that. And thank you also, Sonu, I wanted to say for those beautiful words. So I think with cultural humility, you know, I think the more we know, the more time we spend working in this area. I think, you know, the less we know, and we're always going to be faced with new situations, new permutations and combinations of people coming from different parts of the world, and really not assuming that we, you know what's going on unless we check in with what people are looking for, with what they're really hoping to get from a psychiatric appointment. It may have nothing to do with psychiatry. It may have to do with a letter for their kids' school, or, you know, something to go to housing, or something to help speed up their family reunification. You know, just like people go to their MPs to try to, you know, get sort of advocacy letters. Sometimes we're doing things like that, or thinking about solutions to life problems that have nothing to do with medical school or psychiatry residency. So having an open mind, being creative, you know, listening to what people really want is part of that cultural humility, I think.
Thank you, Dr. Andermann. I had another question, which I thought is amazing. This Addis Ababa project, which you've been part of, it's an amazing project with so many people engaged and supporting it. You know, I always thought about it's obviously it's an amazing project and people want to be part of it. Could you talk a little bit about maybe in the early years of Claire, yourself, and others engage the faculty to contribute, and because it's been so many people have been engaged with it. So I think that'll help a lot of people in their own projects. So.
Yeah, sure. So I think, you know, what I learned from Claire is that, you know, she was out recruiting the best teachers, the most engaging and you know, faculty from, you know, from Toronto to come and really spend a month as volunteers, because you have your accommodations and your flight, but you're kind of volunteering your 4 weeks here. And most people bring home a lot more than they give coming here. And you know, many people have come more than once, sometimes even 2 or 3 times, and want to come back again. So for the faculty piece, you know, we always kind of look, we take our lead from the Ethiopian faculty at AAU if they're interested now maybe more in child psychiatry because of the new fellowship, or people who've done a lot of work in forensic psychiatry over the years, or addictions, or, you know, whatever the area or topic is, we try to find the best people to fit what is needed, but also people who are going to be, you know, not just experts, but people who are going to be happy to sit in a clinic and supervise residents and spend their days with them. And they're long days. You get picked up by a van at 7:30 in the morning, or, you know, get to 8 a.m. rounds, and, you know, you're there kind of all day. And, you know, it takes a lot of dedication. In terms of residents, we have sent out I've always been in charge since the beginning of resident applications, and we've had wonderful residents who really contributed a lot to the trips. They're really like the direct go-between the faculty and the residents, who can kind of be on like those levels to see how the residents in Ethiopia are really enjoying or understanding the teaching. They'll be the ones who will raise their hand if nobody else says anything and kind of tries to break the ice. So the resident piece is also very important. And we have interviews every year or 2 through postgrad, and those are emailed out to all the residents. So right now we've got some people on our waiting list, but when we go through that, we'll be kind of having another call probably sometime in the next 18 months or so.
Wonderful. Thank you. I do want to acknowledge Claire Payne as well, an extraordinary commitment to the program over the years. So there's another question here that in terms of resources, what are the resources you would recommend for learning more about perspectives on mental health and treatment from different different cultures and cultural perspective?
Yeah, there are a lot of resources out there. One is our own Cultural Psychiatry Day, which is now a national video conference. It's free. It's one afternoon. This year, it's at the end of April, usually on a theme, you know, with a panel of speakers and a resident presentation learning about cultural formulation. Last year, it was on spirituality and mental health. We've had things on Indigenous mental health, on refugee mental health, on a whole lot of topics over the last, like since about 2006. Another one is that, and I should have showed a slide, but I didn't want to overpack my slides, is the CAMH Immigrant and Refugee Mental Health course, which is a free online course offered several times during the year. Claire Payne and myself and Kenneth Fung and others have contributed to some of the being content experts for the course. And there's a stream for physicians and health providers. There's a stream for settlement workers. And so if you just Google CAMH Immigrant and Refugee online course, you can sign up for that. It's about 20 to 24 hours. You get be part of a community of practice. There's a lot of content there. And then there are the conferences that I flashed up at the end of my presentation, the SSPC, Society for the Study of Psychiatry and Culture, which was actually in Toronto last year. Next spring, it's going to be in New Mexico. And the World Association of Cultural Psychiatry, which is every 3 years, is another really great like smorgasbord of topics in cultural psychiatry. And one more I'll add is the McGill Summer Institute in Transcultural Psychiatry, which is a month-long variety of courses. You can do credit courses in cultural psychiatry and research methods. There is then a topic that they choose for a 2-day kind of intensive seminar, and then a 1-day kind of more public conference. So it's a great place to go and also meet some of the people in the field who've really written the kind of Canadian map of cultural psychiatry.
Thank you. Yeah, I know we do a wonderful job at U of T, but I've also attended the McGill course, and it's an amazing group of people that collaborate with us, and many people. So thank you for mentioning. I wanted to ask one last question. I noticed in the bio that you had done anthropology, and then I think did a master's maybe in social anthropology. Tell us about how that influenced your career and your work in cultural anthropology and the interface of medicine and anthropology.
Yeah, that goes back a while, but it was something that I always really enjoyed and wanted to learn more about from my CEGEP in Montreal and then undergrad days. I think I've always been interested in learning about how people do things around the world, how they think about their lives, how they think about their health, their illness, their families, and so on. And, I think it's a very good grounding to becoming a psychiatrist. On top of that, I was also not really a hardcore science student, I have to admit. And, biochemistry and calculus were not my strong suits. So just being honest, it's, I also, enjoyed feeling like I could be a better student in those areas. And I think it's really kind of come full circle to be able to use that in my work now.
Amazing. Thank you. Thank you again, Dr. Andermann, for this wonderful presentation. And also, as you said, you're in Ethiopia and presenting here, but in many ways, it makes sense in some of the wonderful work that you've done. So thank you again. I want to thank all the attendees for attending today. We have wonderful grand rounds coming up in a month by Dr. Mark Senior, and hopefully you'll all be able to join us. Please fill out our evaluations and feedback. We'd love to hear that, and we'll continue to work on improving things. So thank you for your understanding as well, because we're broadcasting from another country, another continent. And thank you for all your understanding. So take care, everyone. We'll see you next month. Thank you, Lisa. Bye.
Thank you so much.